migraine management. So I'll be starting my talk, migraine in older adults. So diagnosing and managing headache disorders in older adults can be complex due to various factors, because we know that in pediatric population and adult population it can be straightforward diagnosis, but in older adults it can be sometimes challenging due to various factors. Migraine, which affects about 10% of older adults, can be a challenge due to various factors, which I was mentioning before. So the pure migraine as a cause for headache in elderly population is around 10%. Underlying health conditions need modification of treatment choices, and symptoms may alter or new pattern may develop. The comorbid factors can be a real challenge. It is very, very important while treating migraine. You have to ask about their past history, drug history, and what are the medications they're taking. Apart from that, everything we have to go through. A detailed history is very, very important before we diagnose and to make sure that it's only migraine, not a secondary headache. There is high chance for headache due to secondary causes, and it may require immediate attention for diagnosis and treatment. So many patients get remission of migraine attacks in their later part of life. We always think that people become older means the migraine go away from them. And for women, if they get menopause, the migraine goes away from them. It's not like that. And many people can get new onset migraine in older age. And women can still experience migraine after menopause also. So we should not have that kind of fixed data. It can happen either way. Some patients notice new onset migraine in the later part of life, which I was mentioning. Migraine management in elder patients has additional comorbidity issues like high blood pressure and stroke risk, which need additional treatment plan. They'll be taking antihypertensive medication, diabetic medications, antiplatelet medications. Whenever we choose a drug, we have to keep in mind, especially we are adding a beta blocker, some other drug which can produce vasospasm or vasoconstriction. We should know a thorough drug history before we add the medication for preventing the migraine. So higher index of suspicion for a secondary headache is needed in older patients with a new onset headache. Whenever we see in older adults, we have to make sure we are not missing a secondary cause for headache. We should be very, very careful before labeling them as a primary headache or the migraine. Older individuals are approximately 10 times more likely to have serious underlying causes, and most of the time have different symptomatic presentations compared to younger adults. There may be some presentation variability in the elder population, and they have more chance of getting a secondary headache. So probability of secondary headache increases steadily with age. Secondary headaches include those associated with the diagnosis of giant cell arteritis. All of us know all these possible diagnoses, but sometimes by repeatedly telling that it will be in the brain all the time while we are seeing in the practice, sometimes we tend to miss sometime in a busy OP practice. So whenever we see an adult population, we have to make sure we are not missing a giant cell arteritis or acute onset headache, subarachnoid hemorrhage, intracerebral hemorrhage, brain tumor and metastasis. Acute glaucoma, we have to ask about any history of visual blurring or any ocular headache, ocular pain, all those things. Make sure that we are not missing acute glaucoma presenting as a headache. Hypertension, sleep apnea. Many people sleep apnea experience headache in the morning. And cardiac cephalalgia, I think it's one of the terms that which we don't discuss in the routine practice. Sometimes people with cardiac ischemia, they may experience a kind of headache, especially when they are on exertion or doing some exercise. When they get ischemic pain in the chest, they can get a headache also. It's called cardiac cephalalgia. Sometimes it can be aggravated by nitroglycerin tablet. And cervicogenic pain. In clinical practice, distinguishing between migraine aura without headache, epileptic seizure, and a transient ischemic attack or a minor stroke can be very difficult. So it is very important to make sure that that we are not missing the acephalалgic migraine or some kind of a occipital seizure and TAA or a minor stroke, and diagnosing it as migraine, and they come back again with some kind of newer issues, then we have to revise the diagnosis. Very, very important when you make this kind of presentation. It is not migraine, it's not due to some other cause. Clinically, primary headaches in older adults can be different and atypical. In older individuals, headache associated with migraine is more likely to be bilateral with less photophobia and phonophobia. So photophobia and phonophobia is more common in younger people. It can be less noticed in or maybe less presenting in older adults population. And it can be bilateral. Migraine need not be unilateral as commonly in younger population. Older population can be bilateral. Migraine aura may also present without headache. The careful assessment is needed to exclude stroke, transient ischemic attack, and seizure, which I was mentioning before. The prevalence of aura without headache can increase from 6% to 16% in people after they reach the age of 55. So when we see, in my practice, I have noticed, I think all of you have experienced it, and this kind of acaphalalgic migraine or TIA, and sometimes it present like migraine, they never had any migraine before, or they would have had some history of migraine in the past. So it's very important that to keep in mind that the aura without headache, the chance can increase from 6% to 16% in older population after the age of 55. Finally, migraine attacks in the elderly tend to start up to 60% at night or in the early morning. So this kind of late period headache, the night or in the early morning, can be a presentation of migraine in older adults population. Hypnic headache is a primary headache that affects older adults and develops while sleeping. And I think all of us have seen few patients in our practice, not as common as migraine. Cerebral MRI and 24-hour blood pressure monitoring can be performed in the diagnostic workup of a hypnic headache. They have to keep in mind sometimes the blood pressure can shoot up in the night while sleeping, and sometimes there can be some other cause inside the brain. So we have to make sure it is only hypnic headache, and the patient may need investigations to make sure it is not due to some other cause presenting as hypnic kind of headache. Caffeine taken as a cup of strong coffee can be one of the acute and preventive treatment options. Primary headache disorders regularly occur in older adults, but with less frequency than younger age groups. 1 year prevalence of migraine headache type was 10% in older adults. As seen in younger patients, a transition from acute to chronic migraine can occur in the elderly with and without medication overuse. So the most of the pattern like medication overuse headache or the migraine pattern of headache, acute kind of migraine or patient developing chronic migraine, those things can happen in both younger population as well as the older population. The transition from acute to chronic migraine can occur in the elderly as well, with or without medication overuse. So overview of treatment options for migraine management in older adult. Lifestyle modifications, behavioral modalities, avoiding opiates and barbiturates are helpful in this special population. We don't use opiates and barbiturates routinely in our practice, but if you take the international data, that these drugs can be given as a painkiller, sometimes in the intractable headache on a routine basis. We don't use it in our setup regularly, but we have to be very careful in treating with this kind of medications. So lifestyle modification, behavior modalities, appropriate medication are very, very important. The best course of action for preventive medication can be stated as a start low and go slow. We are not in population. So we have to start any medication very, very low dose, and we have to go very slow. Once the patient becomes better to stop with the dose rather than going on increasing the dose. In addition, procedures such as Botox injection, nerve blocks, and neuromodulation devices can be used. Comorbidities and medication issues in the population. Headaches are common side effect of cimetidine and ranitidine, sulfonamides, and like trimethoprim, sulfamethoxazole, nitrates, and spironolactone. We use these drugs routinely. I don't know how many times we given spironolactone and patient complaints of headache, and these drugs, one of the known documented side effect is headache, spironolactone, sulfonamides, and nitrates we know, and ranitidine sometimes. So acute medications, the medication interactions are very, very important in adult population, older adults population. Careful use of vasoconstrictive medication should be practiced due to risk of coronary artery disease in the elderly, especially when you are using the ergotamine kind of medications. Still, people use that as wonderful drug for acute migraine, but cheaper and best. But you have to be careful in CAD patients. It can produce problem, or even people prone for CAD, or people have underlying silent vascular issues can go for a vasoconstriction. NSA can cause side effects including peptic ulcer, gastric hemorrhages, and specifically when combined with anticoagulated therapy. So it can produce problem in people who are taking anticoagulated therapy, and in addition, and NSA can produce a lot of other issues. NSA can result in acute renal insufficiency, nephritis, proteinuria, and edema. Antiemetics give a higher risk of extrapyramidal symptom as a side effect. The elders are more prone for extrapyramidal side effect compared to the younger population. So preventive medications, avoid or limit tricyclic antidepressants due to risk of cognitive impairment, urinary retention, and arrhythmias. Beta blockers have an increased risk of sedative effect, conduction abnormality, asthma, glaucoma, depressive symptoms, and diabetes. They're probably safe to use in elder patients with heart failure comorbidity. Valproic acid might increase liver enzyme disorders, bone marrow suppression, delirium, tremor, ataxia, and in a rare situation, a presentation called pyramidal syndrome with dementia. It's one of the very not unusual side effect of valproic acid in the population. So topiramate also has many side effects: nephrolithiasis, weight loss, sedative, cognitive side effect of agitation in the older adults compared to the younger population. I always write in the prescription that if you feel any blurring of vision, stop topiramate, come back to the clinic for review. And I also ask them to go for a periodic ophthalmological examination, because these people can go for silent glaucoma and can get visual defect. Then they may come and say, not mentioned or you're not informed to me that this can produce this problem. So I routinely write that in document of the prescription, and I prescribe the patient on topiramate. Verapamil has been associated with gastrointestinal bleed as it has antiplatelet effect. And CGRP blocking medication will be used in older adults when appropriate, with consideration that multiple clinical trials testing these agents had age limitations and older adults were not enrolled. So we can extrapolate the data, but we have to keep it in mind. And that what age most of the studies are taken, and what kind of age, what patient they had. Sometimes people 75, 80, 83, they come with kind of headache, and we have to be very careful in prescribing medication. But this kind of study are done for this kind of population. So medical interactions and medication side effects are important consideration, especially if headache develops in relation to starting a new medication or dose change. It is estimated that 8% headache may be attributed, at least in part, to the use of a specific medication. In a study evaluated charts of 239 patients with migraine who are older than 64 years of age, it was concluded that the frequency of migraine for these older patients was higher. The first onset of the migraine episodes occurred before they were 18 years of age. So it can happen, people who had migraine at the younger age, it can happen again at the age of older adult stage. If migraine onset started prior to the age of 18, 1 in 3 of those patients would have migraine that persisted in older age. It's not that it's disappeared when they become old. It can persist in a particular percentage of patients who had migraine started before 18. So in older adults, primary headaches are diagnosed as exclusion, and treatment is affected by comorbidities and polypharmacy. Secondary headaches are a major consideration requiring appropriate workup. We have to always make sure we are not missing a secondary headache. Most headache treatments that are given to younger patients can be offered safely to older adults. Thank you very much.